Welcome to Mind Over Matter. Today it's a pleasure to have Dorothy Brozek. We're going to be talking about the management of chronic pain. She is a CL psychiatrist for Health South Pain Unit, which is at the New England Rehab Hospital, also a substance abuse specialist, which I think figures very nicely into the topic itself. So perhaps we could start today by talking about chronic pain. What is it? Why is it? Who has it? And why is it so hard to treat?
Well, the first thing about chronic pain is that it really is very different than the everyday pain that we all experience when we step on a tack or burn ourselves. In that instance, it's a signal. It's the body's way of telling us there's something awry and we need to change it. And it's a good thing. However, in the circumstance of chronic pain, which is defined as more than 3 to 6 months, generally 6 months is what most of the literature says, of pain that is beyond the point of tissue repair. So basically, you're kind of stuck with this situation, and everything has basically been done surgically or otherwise, and this is kind of what you're left with. What chronic pain patients experience is so much more than just the pain. The focus on a certain body part with time tends to change to a rather different phenomenon. That is, rather than just having your headache or lower back pain, you find yourself in a full experience, including your body, where your lower back pain might become a neck pain, and then your neck pain causes a headache, and the next thing you know, your whole body is somehow in this dance of pain. And then emotionally, people find themselves getting more inwardly directed and distracted, to the point of feeling like they've kind of dropped out of what's going on in a conversation. In my own experience, I have seen patients in a group therapy. We do a group therapy at Health South Inpatient Pain Unit where I work, and the name of my group is Mind Body Group. And I will see a patient suddenly drift off as they get into this internal preoccupation of pain and really not externalizing anymore in the group. When this happens in a group, we're able to point that out and allow the person to be encouraged to re-enter. But if this happens in a social situation at the dinner table repeatedly or at work, you can find yourself in a situation where the chronic pain patient is really being left out of what's going on, and people start perceiving them as odd or preoccupied or not available.
Well, let me just ask, though, you're saying that there's like a march of the symptom. Is that always the case with chronic pain syndromes, that it starts, say, with some major problem in your shoulder or your hip or whatever? Inevitably, as it moves into a chronic phase, it spreads?
Well, it can, but not exactly. The point I was trying to make is that it could start out at one body part, but with time, as it's chronic and it's unrelenting, that the whole body becomes involved. It might be a way of the body trying to manage it, that you don't necessarily feel the pain as sharply, but your whole body becomes involved. And then, more importantly and crucial, is that it's a mind and body experience. That's the name of my group that I run, is Mind Body, because once your pain is that unremitting, it becomes a full phenomenon, including your emotional life. The mind and the body, in terms of Western medicine, is considered more separate than in other traditions, such as Eastern religions and traditions of healing. So this mind and body becomes one unit where the whole being, the person, is consumed by this pain to the point where they tend to drop out socially, find themselves preoccupied with the pain. Their primary object becomes, rather than others, becomes pain and the self. Add to that people start taking narcotic medication that has cognitive fuzziness as a side effect, and you have a problem.
Okay, but before we get to that, though, I mean, what makes it chronic? I don't mean the obvious, but I mean, why doesn't the body eventually do its homeostatic thing and make accommodations? Why does the pain in the absence of a disc or a bony spur or an obvious chronic irritating etiology, why does the pain persist? I guess part of it is I'm edging up to a question of how much of it is physical and how much of it is psychological.
Well, I think that is a very touchy question, because none of us like to feel like, you have this horrible pain and you can't work because it's your mind and you should fix it. And that's kind of implicit when people talk about that it's your mental problem. Mm-hmm. What happens with chronic pain is that there exists some kind of a problem with the body that with time doesn't subside. And it can be a true physical problem that is not amenable to surgery. Tissue healing has already taken place, and it continues, such as fibromyalgia, which is a very controversial diagnosis, and a lot of people have different feelings. But basically what it is that the nerve, our nerves are all over our bodies, which are our sensors for pain, somehow become entrapped in the fibrous elements of the muscle and tissue, and that there's nothing that can be done to fix it, but there is some kind of structural problem that continues to render that nerve misfiring, in that it's not signaling anything anymore. It's basically, chronic pain is when the signal no longer is signaling something that we can help, but the signal persists. So it doesn't mean that it's the person that the person's mind doesn't become involved, because I think anyone with time, you have enough pain long enough, and your whole consciousness and being becomes focused on this, and it's understandable. But it's there are times when it's something that cannot be found. There's something that no imaging, no MRI, no X-ray can show, but the patient is truly experiencing this, and the nerve itself really is misfiring for whatever reason. So.
Well, without being in any way pejorative, though, I mean, aren't there possibly psychiatric components? And I don't mean necessarily secondary as an outgrowth of, but primary?
Oh, primary psychiatric illnesses that cause people to experience pain?
Yes.
Yeah, I mean, in terms
of... Well, where the illness itself is being experienced as it's kind of being somatized. The body is speaking out, but the underlying issues perhaps have more to do with body image and depression.
Yes, absolutely. That can be. And if that is the case, then our such as maybe the viewers have heard of conversion reaction. It used to be more prevalent at a different point in history, which has many different possible reasons in terms of the society and people being allowed to be more free these days. But at the turn of the century, it was not all that uncommon to find people who were blind, who had no physical reason to be so, and found themselves not being able to see, and they were not faking it. Called a conversion reaction, and we still do see this. The treatment for this is to continue to treat the patient with dignity and acceptance, and that with time these symptoms tend to subside. But oftentimes these mental disorders do overlap, kind of like the Venn diagram. There is some overlap of this psychological component. But I don't think that's any different with something like pain or any other physical illness. If you're a cardiac patient, your emotional outlook will have something to do with perhaps when you will become ill or otherwise. I think that's always a component. I think this mind and body split is a product of our own need to organize rather than the way the body really works. The mind is always with us.
So is, for example, we'll get into treatments that, I mean, at what point in the progression of the chronic pain syndrome is psychotherapy included in the treatment plan?
Well, the fact that I think Health South is very progressive in our psychiatry department, using psychiatry on a pain unit. Now, I do psychotherapy, but I also am responsible for some of the medication management along with our physiatrist, Dr. Ho, who also does acupuncture and different modalities. But the psychotherapy component is a piece of it, but it's not an add-on piece. It's an integral piece of the program. In the 60s, there were two researchers, Mel Zack and Wall, which is a very well-known duo, who postulated the gate control theory. And that tells us, and this was done as a formal research project, that thoughts, emotions, and physical condition of a person all come together to actually gate how much pain the patient experiences and in what way. So if you are a person who thinks positively, who feels you have a sense of control, who feels that you can have some degree of making your life different by your own volition, who are willing to try new and different avenues, who understands that you become internalized with pain and the need is to externalize, to orchestrate your life in a different way, such as telling people that you do have pain, that you might not need to stand up during dinner time, and to do this as part of your life to take care of your social life, then you're in a very different position in terms of how you're going to experience pain. I think anyone sitting alone in a room is going to feel a lot more miserable than someone perhaps going to dinner with family and standing up at the table because of their sciatic pain is acting up, and to be able to cope with that and feel okay with other people. The tendency is for people to isolate when they have pain. They feel ashamed, they feel foolish, they think people think they're faking, they might be taking narcotic medication and look a little tipsy. So a lot of these things come into play that tend to make people isolate and not stay engaged.
Okay. Well, we'll take a break, and then perhaps we can talk about medication and some of the techniques you use for the control of chronic pain. So thank you. We'll take a break.
You're looking at soldiers, citizen soldiers and their families, members of the Army National Guard. They train part-time to be ready when they're needed by our country. They live in your communities, building civilian experience, pursuing higher education and personal goals. They're friends, neighbors, teachers, accountants, fathers and mothers, sisters and sons, getting good pay and benefits while giving something back to the country they love. Join them. Call 1-800-GO-GUARD and discover the part-time job with full-time pride.
In the Army National Guard, you can.
This is me. And my mom and dad. And my big brother Alex. And Jack. This is the day I learned that sandals got their name from sand. That jellyfish aren't made of jelly. That stars don't just come from the sky. That the ocean is bigger than all of us. This is the day we all got to forget I was sick. This was my wish.
All right, why don't we talk a little bit about traditional and non-traditional treatments You started earlier, and I interrupted you, talking about painkillers. Maybe that's a good place to begin. What's their role? What's the problem? And of course, I'm always interested in the whole general phenomena, when our doctor's part of the problem.
Okay, that is a very good question. The very first thing about narcotics is patient education. I think that many people don't realize that a phenomenon called selective tolerance develops with narcotics. That means that selectively certain phenomenon tend to how to put this, that when you have pain, that when you'll need more and more medication to treat that pain, but the other things such as cognitive slowing, physical inability to operate machinery, those kinds of symptoms will continue to accumulate even though you're going to need more and more pain medication to treat the pain. That wasn't particularly concise, but you get the point. You need more pain medication to treat the pain, while the other things such as respiratory depression, your inability to operate machinery, you're getting fuzzier. So this is a problem with pain control. The patient is naturally going to want to take more medication to treat the pain. And with time, you're going to need more pain medication to treat that same pain. But you're getting fuzzier, you're getting more dysfunctional, and people are looking at you looking glassy-eyed, and it causes a lot of social problems. So that's the very first thing we have as part of our program, is some patient education about how narcotics work and how you need to be very cautious to not get on the trap of taking more and more narcotics.
So you're going to give me narcotics if I'm in your program?
Well, we give you narcotics in the beginning, but the goal is to get you off the narcotics. An inpatient pain facility, generally the patients have to be ill enough, or this can be done on an outpatient basis, and ill enough meaning that we need to have you inpatient for some reason. One of the biggest reasons is that you're on narcotics and you need to be detoxed. The role of the physician in this is complicated. We as physicians want to help people. You have someone coming in writhing in pain, and many people will say, why don't you give mom, pain medication? She's a person who is an older person. She should have some quality of life. Well, that sounds like a good idea. But if you start giving mom tons of narcotics to treat the pain, and this tolerance develops, meaning mom will need more and more, she'll get more and more fuzzy cognitively. She might fall. She's not thinking. She becomes internally focused. She cannot no longer do the things with her hands that she had done. And you have a person who's a very different person who might be a little more comfortable. Apparently, she's not writhing in pain, but she's out in la-la land. So when this happens, yes, it is the physician's responsibility to monitor this, but I think it's also families' responsibility to understand how some of these medications work and why doctors are sometimes reluctant to keep prescribing. This is a major problem because many patients feel desperate and they will go to several different doctors who unwittingly keep prescribing. And if you want to get narcotics, that's a way of doing it. But with time, you find yourself in this quagmire of a dilemma of treating your pain or having a life.
Well, let me ask you to go over that again lightly. Let's say I'm an inpatient on your pain unit. First of all, what's my average length of stay as an inpatient?
Well, average is probably somewhere around a month, but depending on how much narcotic medication you are on. We have people who sometimes are on tremendous amounts of narcotic pain medications. And doctors, I think, try to help people who have some dreadful injury. People who have been horrible accidents, burn patients, patients who have fallen from heights that have, basically broken every bone in their body. With time, their fibrous changes and this chronic pain syndrome develops. This pain is no longer signaling anything but keeps on firing. And these patients can be very good people who are not addicts, which puts you in another category in many people's minds, who, get prescription drugs from their doctor. So you know,
So you don't see many people who haven't been down that outpatient road a little bit. Most of the people who apply for inpatient pain management have been seen by a physician, have already had some outpatient narcotics, for example.
yes, yep.
Okay. So, all right, I present and I'm in agony. My back is killing me. And the medication the doctor is giving me isn't helping, and he won't give me any more, and he suggested I apply for admission here. How are you going to handle me? Could you maybe take me through the program?
Okay. The very first thing is the patient education component. People who are coming into the hospital have to be prepared that our goal is going to be getting the person off of narcotic medication. This is not an easy thing, and many people have to think long and hard if they want to go through this process. It's scary to think of having pain. But what we tell the patient, and what we do, is to have a different conceptualization of dealing with this problem rather than just obliterating it with narcotics. Interestingly, many patients who take narcotics medication for some time will be able to feel their way through the blur of what narcotics can do, and they can still sense the pain even though they feel a certain sense of detachment from the pain. And when we get a patient who is able to see that in their own experience, they're a great candidate, because part of our methodology is to teach you to live in your body rather than be your body. This sounds very esoteric.
I was going to say, so I'll say, yeah, that sounds good, very interesting, I'm all for it. Oh, by the way, it's time for my 3 o'clock dose. How many people kind of buy into it, and do you successfully, because obviously you're stressing that a lot of your initial work is detox.
Yes.
And switching to alternatives.
Detox meaning that we convert, all narcotics are basically the same medication, whether it be Percocet, oxycodone, OxyContin, morphine, Vicodin, you know, that whole class of drugs. We convert the person over. First, we figure out how much they need. So we need to observe them and see, basically on an as-needed basis, which is called a PRN. We calculate how much medication the person necessitates. And then we, over a period of...
based on what I'm on already?
Based on what you're on already, to a certain extent, but also what you tend to be asking for extra over the first few days. So many patients, you know, don't take pain medication like clockwork at home. They take it when they need it. So we have some standing order, straight order that they get maybe 9, 3, and 11 o'clock at night. Then as needed medications, we calculate that and then convert that narcotic, whichever it might be, into a liquid form. And then we taper it so that the patient focuses on just getting the medication, not looking at how many pills, and to try to develop some distance between how many pills am I taking, how many milligrams, to just taking this medication in a cup form. It's a liquid. You don't focus on it. You focus on functioning. You focus on alternative ways that we teach. Okay. And the emphasis is away from the narcotic onto other avenues that can help you deal with pain.
So at that point, you've taken my PRNs away.
We've taken everything away except several doses throughout the day.
By the clock.
By the clock of this liquid medication that each and every day is a little bit less, but not enough where any given day you'll go through withdrawal. Physiological withdrawals is uncomfortable. And, you know, your blood pressure goes up, you get sweaty, you feel sick, you have GI upset, and we try to avoid that and do that by a slow taper. And we've done very well. We also have people in fitness activities, getting strong in a rehab setting. We have pool, and also cognitive and mind-focused therapies, such as learning how to meditate, learning how to take your mental energy into a different space. That sounds a bit vague. Let me give an example. When people go to the dentist, we it's kind of natural to kind of be figuring out what the dentist is doing. So we follow every probe and drill and kind of practically visualize, and it's kind of like driving in the passenger seat along with the driver. You really don't need to be looking out the window and as if you're driving, and you really don't need to be following the dentist's every move as he's probing around that particular molar. With nitrous oxide, which is a medication that used to be more popular and still is used mostly with children, you really don't care what the dentist is doing because you are using this drug to kind of space out and not pay attention. This can be done without drugs, and this would be an interesting experiment for you viewers. The next time you go to the dentist, don't follow what the dentist is doing. Make believe in your mind's eye that you're in the Bahamas lying on a raft in the sun and just basking in the sun, and take yourself mentally away. These kinds of skills are called auto-hypnosis or meditation. There's lots of different words for the same thing. It basically allows you some mental choice to not have to stick with your body through every single thing it experiences, and you can take your mind away somewhere else. This type of skill, we call it hypnotic talent. Not that, oh, I can't be hypnotized. Most people have to learn to be a good hypnotic candidate. And this is by using your mind and creativity to take yourself mentally away from a situation so that you're not having to feel the same experience in that dentist chair. And this is an example of what we teach people to do by breathing, relaxation, imagery. And it's very creative, and many people just get a real kick out of it just in terms of the creative aspects.
So I'm in this program. We're leading toward a break, too.
Okay.
I'm in the program for 30 days. Is that my contract with you? And I guess one of my questions, is my insurance company paying for this?
Yes, insurance companies pay. It is, it generally has to be, this day with managed care, it has to be cleared. And I think the insurance company basically would want to know that this couldn't be done on an outpatient basis more cheaply. I mean, insurance companies are in the business of keeping costs down. And if you are a person who needs detox, that generally isn't a problem to get in an inpatient unit.
It is not?
No, if you have been on narcotics and you're getting into this difficulty. But, you know, like every insurance company, there has to be someone that's advocating for you to present this.
Good. All right, well, let's take a break, and maybe let's pick up with my treatment on your unit and look at the differential diagnosis, and then we'll get into alternative treatments.
Okay, great.
Thank you.
They came from every corner of the country. From small towns and big cities. But they all shared one thing in common. They belonged to a family called Marines. A tough and determined few, dedicated to protecting everything we hold sacred. And still they come. Celebrate the 225-year history of those proud few who have earned the title Marine.
We formed the Geriatrics because we love hockey, we love to skate, and we want to play. We're all over 60, so what? We travel around the country, we'll play any club, anytime, as long as they're on Social Security. You know, people say to me, you've had 2 hips replaced, why don't you slow down? I had the hips replaced so I could speed up. It's the best thing I ever did. 5 years ago, the osteoarthritis got real bad. Never thought I'd get back on the ice, but now look. No pain, moving like a ninja. My advice, don't throw the whole car away just because you need new tires.
For more information on getting your bones and joints back in the game, call the American Academy of Orthopedic Surgeons or visit aaos.org.
So let's continue. Take me through the treatment program. You're explaining to me that I'm going to be tapered, and I'm indicating, at least for now, a willingness to go along with the program. And now we're into sort of you're trying to help me understand, I guess you'd call it alternative approaches. So define some of those, please.
Okay, the first thing is a basic difference in relating to pain. We have as our goal not pain cessation, but pain management. That the patient will try different ways of dealing with the situation rather than just using narcotics to obliterate. And I'm repeating myself, but the patient who's taken narcotics for a long time will often be able to experience the pain through the fuzziness. So many patients are pretty ready to try something new. Now, some patients don't have that happen, and they feel that the pain medication, the narcotic pain medication, does do the trick, but they are sick of the fact that they don't function and that other people look at them as addicts and that they've kind of withdrawn from the world. So the very first point is to really underscore and point out to that patient and have them say themselves the negative impact of narcotics on their lives. If a patient can get to that point very clearly, it's a whole lot less problematic. If the patient cannot really commit to the fact that the narcotics have caused that much of a problem, we oftentimes get families involved who let them know how much the narcotic medication has affected their lives. So it's not the patient in isolation, but in the context of a family. The next thing is to allow patients to use some different modalities that some patients have more experience than others. Anyone who's done any degree of meditation, TM used to be popular at one point in time, not so much these days, but basically using your mental capacities to, first of all, to believe that your mental capacities can make a difference in how you think and feel. We don't just think and feel naturally. We oftentimes can guide our thinking and feeling to a certain degree. Now, of course, there are some feelings that are going to be there, but we can guide ourselves to feel and think differently, such as when you awaken in the morning, if when that alarm clock goes off, you immediately, pound it and say, oh my God, I have to get up, it's horrible. That's going to kind of color your day. And we have patients take note of what kinds of messages they feed themselves. It's always going to be this way. I'm a hopeless case. It's never going to get any better. My life is over now. This type of negative thinking is, first of all, recognized and addressed, and it's done individually as well as in a group therapy situation. Like I said, my group is named Mind Body Group, and other physical therapy, occupational therapists that work with patients are all on the same page in terms of looking at what the patient's negative self-messages are and other ways of looking at life. One is that you can have pain, and I think I said this before, you can have pain alone, or you can experience pain with others. If you're with loved ones, having a social life and having a life of any sort, like getting out of your house, that's a very different quality of life than being in bed with the covers over your head on narcotics. So just pointing out the negative aspects of the narcotics, the social withdrawal that has come about, and encouraging patients to address their negative thoughts and try new ways of doing things. Depending on the patient population, because we can have a range of people in terms of their abilities to grasp some of these concepts. But
all ages?
All ages.
Kids too?
Oh, no, we don't have any children. The youngest is usually around, we don't take pediatric cases, but in their early 20s and up to very old people. It's always very interesting because some of the people you don't expect to be able to get creative in this way in terms of meditation, thinking about their inner life, being able to examine how they're feeling, being able to try on new ways of thinking and feeling. It's not necessarily the younger folks who do better. Some very old people, you can't teach an old dog new tricks, is really not true. Older people oftentimes do very, very well in learning how to manage the emotional energy that they put into their lives. You can put that emotional energy into your pain. Oh gosh, I'm feeling this pain in my leg. I don't feel well. Me, me, me. That's what happens. And it doesn't mean a person's a selfish person. This is the natural progression, as I stated earlier, from externally driven life to the internally driven, pain-driven life. We encourage people to breathe, to be creative and not focus on that pain in the lower back, or maybe feel the pain in the lower back and through hypnotic techniques of relaxation to spread that pain over a larger period, a larger area rather than one pinpoint, kind of like the image being dropping a blob of ink into a pool of water as it dissipates, to imagine that, imagine your back at that spot, and the pain is dissipating and spreading and getting lighter and lighter and less problematic as the patient breathes. Also images, positive images, taking oneself away, like in the dentist chair, like I spoke about earlier, where you can take your mental energy away from the pain and have a very different experience.
It's very interesting, and I think it's very, very exciting. I don't want to sound cynical, but you must encounter a number of people who sort of say, yeah, now when do I get my afternoon dose? That kind of thing. And I guess that's also a cousin to the next question, and that is, how many people don't complete the program? In other words, I assume they sign out anytime they want to.
Oh, yes, absolutely.
It's voluntary. So do you have some impressions on, say, the number of people who do versus don't complete the program?
It's rather amazing that the large majority complete the program.
Really?
This does not mean that people don't come back, and it's not that often, but we do get people who, once again, start feeling badly, start going to get narcotics, and this problem creeps up again.
Okay.
I think it's...
You don't do aftercare, follow-up, you refer?
Well, depending on the patients, because some people come from a long ways away. There aren't that many rehab hospitals around, particularly inpatient pain units. So oftentimes people live far away and they're not going to come to us for their aftercare. We do have an aftercare department, and I actually do not see the patients in aftercare as the psychiatrist, just because of my constraints of time. But Dr. Ho, our physiatrist, sees the patients in aftercare. But the vast majority of patients start out, I think, thinking, oh my God, I'm going to get rid of my pain medication, and that's basically why I'm here. They're not really thinking that there's going to be another way of conceptualizing the pain and dealing with the pain. What's helpful is having a milieu. We have other patients at different points of the program, and oftentimes the other patients are the ones that are most convincing.
How many, by the way?
It varies.
Well,
it varies. 6.
Oh, it's small.
Sometimes 12.
Okay.
Sometimes none.
Okay.
That hardly happens, but for the most part, around 6, and enough where the ideal number is somewhere around 6 to 10, where there's where we can do these groups where patients can share experiences of pain management, social problems that develop, feelings. Many patients are very ashamed. They feel foolish that they're taking narcotics. They feel ashamed that they're glassy-eyed and have slurred speech. They feel embarrassed that they're no longer working. Marital issues, financial issues. So all these things come into play in terms of not just talking about getting off of narcotics because you can't get the pain medication anymore, but the impact on the larger picture, which is a person's entire life. Many people end up having terrible marital difficulties when one party is taking a lot of narcotic. That person isn't particularly interesting anymore. They're inward. They're not interested in socializing. They're not interested in talking, and it can make for a very, very difficult situation. So, the milieu is a big part of the treatment.
Okay. But so there's a small number you're suggesting who kind of sign out at the point where their dose gets to be too low in their estimation.
Yeah, it is a small number. I think the reason that the number is small is that we do prepare the patient for the treatment that they're signing up for, and that is to get the person off of narcotics.
Now, this is a chronic pain, but it's gotten kind of a little bit blurred with addictions too. What if someone presents to your program for a 30-day withdrawal? They want, in other words, to withdraw from painkillers because of an addiction not necessarily driven by chronic pain. Is that unit open to you?
No,
or
it's
open
not.
to them?
That's a very good question. And actually, Dr. Ho and I have worked very closely to make sure that patients like that, and I
Not
actually...
a detox, in other words.
Right. We do not take those patients. Patients who have that primary, and I actually work in the community with severe addicts who mostly heroin these days. And that's a very different type of treatment.
Okay.
Those patients are better served in a psychiatric facility than in our facility. So that's the big cutoff point where we really try to make sure that those patients do not come to our unit because there is a different problem that needs to be addressed.
So you need to know that the centerpiece is really the pain.
Right.
Because you want to take these people to really alternative approaches to the management of their pain.
That's right.
Okay.
Right. That's the most important part of our triaging from the get-go. Is this person primarily a substance abuser, or this is a person who has chronic pain who has secondarily become addicted to narcotics? They are physiologically addicted.
A brief question before our break. What percentage of your patients successfully leave the program on a narcotic?
It's really, oh gosh, percentage.
Well, I mean,
hardly ever it happens.
Hardly
I can
ever,
think of a few people. One was a very, very elderly woman who, you know, in her 80s, who really did try to not be on narcotics, but did not have the emotional capacity to really go through with it. We got her down to a substantially less amount of the narcotic, but no, but it hardly ever happens.
Hardly ever happens, okay. Well then I guess in our last segment after the break, I guess we should look at hardly what does happen. So we'll take a break. Thank you.
As time flows on, there are places we return to again and again. Places that comfort us with their serenity. Places that astound us with their beauty. Places where our memories come to life. Precious places, timeless places, places that with your help can endure forever. I'm Paul Newman. Help the Nature Conservancy save the last great places around the world.
Good night, Russ.
Good night, Russ.
Good night, Russ.
Every day, more and more tax professionals are embracing IRS e-file.
Night, Russ.
So instead of printing your income tax returns, they're sending them electronically.
Good night, Russ.
Good night, Russ.
E-file is accurate, secure, and faster than paper.
Good night, Russ.
Good night, Russ.
There's no printing, stuffing envelopes, or licking stamps.
Good night, Russ.
Which means you'll get your refund in half the time.
Take it easy, Russ.
And even faster with direct deposit.
Russ, don't work all night.
Insist that your tax professional use IRS e-file.
Happy anniversary, Russ.
And please, help Russ get home to his wife. Visit irs.gov to find a tax professional who uses e-file.
So you've suggested your treatment and gradual kind of tapering doses. What are some of the other treatments that you recommend? Perhaps I'd also be interested in hearing what are some of the other medications that you sometimes use in the pain management realm. And then, of course, I'm very interested in alternatives, acupuncture, and some of the other methods that you apparently seem to rely upon in your service.
Well, medications are not all created equal, and a narcotic medication is a big gun. And what we call a big gun is something that really impacts your quality of life. If you're fuzzy and you can't think and you can't work and you're not focusing and you're inwardly directed and you're looking high, that's a big gun. So there are non-narcotic alternatives. Some of the anticonvulsants, people might have heard of Neurontin, Gabatril, carbamazepine, Tegretol. We use antidepressants. Oftentimes can be very helpful for the treatment of...
Can you name a few that you find helpful?
The serotonin reuptake inhibitors, Prozac, Paxil, Zoloft, they have not been considered empirically to be really great, but they're used, and for some patients they work. Also the tricyclics, which are the older antidepressants that people do not see as often, Elavil, Doxepin, we use these as well. Plus, plain old Tylenol can be a very good thing, but patient education, once again, that
Tylenol in particular?
Tylenol can work real well.
As opposed to aspirin, as opposed to...
Aspirin, Tylenol, the regular...
Just in general,
and ibuprofen, all those things. But once again, Vioxx, which is the newer COX inhibitor, it's called, for rather than using what many people used, ibuprofen. This is really the next step in terms of pain management. But all these medications can be effective, but crucial is patient understanding and patient education that these are not innocuous medications, and that it's not okay to take that Tylenol around the clock every 4 hours, even though it says on the bottle you can, because there are possible toxicity issues with the liver, with ibuprofen, with the kidney. So we let the people have some control by their knowledge, not only in the hospital, after they leave the hospital, of how they're going to manage their pain. Other alternatives are how one holds one's body, posture, alignment, moving properly. There are many, it doesn't have to get into anything real fancy, just holding your body properly, body mechanics, sitting properly, learning how to use your body in the most effective way so you don't incur injury. Some people have heard of back school, and you learn ways to protect your body from injury. Body mechanics is a course that is taught in nursing school, and nurses learn, picking up heavy patients, how to protect themselves from incurring injury. We teach these things to patients. Also, other alternative medications such as acupuncture, using injections, trigger point injections, where steroid or medication is injected locally to stop these foci of pain that for many people works real well. Sometimes it comes back, sometimes it doesn't.
Talk about acupuncture for a moment, your experience with it. for, say, chronic pain?
Well, acupuncture is something that is not a Western modality. Needles are inserted in people where it's not acupuncture. It can be a Western method where the needle is inserted perhaps with some medication, and you might think you're getting acupuncture, but you're basically being treated in some way that the Western concept is Western medicine, and that is something to do with the nerve. Rather than acupuncture, which works on a totally different system called meridians, which are energy channels that is completely nothing to do with our Western system, where needles are inserted to change energy flows throughout the body. So just because you're getting needles doesn't mean you're getting acupuncture. You might be getting a Western variant of using needles for nerve conduction rather than for energy flow.
And I
but
assume
both are
you think
used.
one seems to be more useful than the other?
Well, actually, for some patients, I've seen both of them work very well. One thing, though, that I think I would be remiss in this talk if I didn't address is the problem, though, of comorbidity with other substances. Many times when people stop taking a narcotic and they go home and they resume their lives, the emotion, even though you might be doing very well physically, you've learned to manage your pain, but the emotional relief that narcotics have provided for some people can be a very troubling phenomenon. When you take,
it's hard to give it up.
It's hard to give it up. When not only for your pain, but you don't worry so much momentarily, quick fix, but people can become psychologically addicted to that feeling. And the most available drug of abuse in our country, of course, is alcohol. So this is something that we talk about throughout the program, is to be careful of this comorbid possibility of alcohol abuse. These days, there's some very, very exciting and new treatments for alcohol abuse. I'm also involved with this in a program called the Alcarest program, that for some select patients, we teach using pharmacological treatment and a very carefully applied counseling support system, retraining system to allow people with certain types of alcohol overuse to learn to drink differently, to learn new ways of approaching alcohol, and to find other ways of getting good things out of life rather than looking for the alcohol in a non-abstinent way. This is very different. It's not the AA model, and it's not to say that I don't believe in the AA model for very many patients, but these days there are alternative treatments for alcohol treatment that does not require abstinence for all patients. Some patients, given their clinical history and their background, need to be abstinent, and because of it has gotten to a point where that's the best treatment for them. But these days, there are alternative treatments for alcohol management, for moderate drinking, that are exciting and that many people are not aware of. It's been popular in Europe, but we offer all these alternatives to our patients and also let patients know if we think that, from what we've observed of them, that they would be good candidates for these types of treatments. But the comorbid substance abuse problem is one that is built into our program because it's such a high prevalence of people getting in trouble after they get off of the narcotics with alcohol. Alcohol being legal.
Correct. So you're saying that some people go home and stick to the program, but supplement it with maybe too much alcohol. Or
yeah, they've gotten used to the narcotics. Not why we prescribe the narcotic to begin with, but the emotional escape can be very appealing, particularly when your life might have gotten into a lot of trouble during the time you've had your chronic pain and been taking narcotics, and your business slipped and you're not doing as well. You might welcome that emotional escape mentally, and this is something we talk about throughout the program, that this needs to be acknowledged in yourself and to take action before it becomes a problem.
Okay, so we're wrapping up the program. We're wrapping up my 28-day stay. Let's say I'm a typical patient. I've done well in the program. I'm no longer taking narcotics. Can you sort of outline what a typical set of prescriptions and a kind of a treatment plan recommendation you're likely to give me before we say goodbye and I go home?
I think the very first thing is that we underscore that in our program, hopefully you have learned conscious living. That is, that you look into yourself in a very deliberate way to figure out what's going on. So you pre-plan your day. Have a long day today. I'm going to be at the office all day. I'm going to need to plan maybe 15-minute sessions throughout the day of lying down in a way where I get some relief from my back pain. I'm going to orchestrate this day in advance so that I don't find myself suddenly in horrible pain. And this is part of what you're learning throughout the program. So to orchestrate your day in a conscious way where you take stock of what's going on, to make sure that you're doing everything possible to continue living fully, that you do make plans, that you don't fall into the habit again of saying, oh, I don't feel well, I shouldn't make plans, I might not be able to go, they won't understand, to take care of that social piece where you let other people know your situation, that you may not be able to make it, but you're hoping to make it, and to explain to other people your situation. So it's the consciousness, it's living in the context of a world and utilizing the strategies that you learn on the unit, such as the self-hypnosis that is done on a regular basis. It doesn't mean it has to take up your whole day, but several times throughout the day, your task is to tune in to what you're feeling and to do this skill that with time you become more and more proficient to be able to manage your pain without narcotics. And to take the medications that we prescribe, which are non-narcotic.
Now, I understand it's a serious syndrome. Risk of suicide is inherent in the condition because people do get worn down.
Right.
A comment about that?
Yeah, that is definitely. People tend to get worn down. When people become suicidal, and I think that shift I'd spoken about of being external to internally driven. You're more alone, your wife leaves you, you lose your job, you're high all the time, you're in bed. The risk of suicide is high. And we do talk about a crisis plan that if you start getting into trouble again, or you find yourself seeking out narcotics again, that you get help right away with someone.
Can I come back to your program?
People do come back. People do come back. For the most part, our recidivism, which sounds like a negative thing, but it really is not a negative thing. If a person needs to come back to do this process again and to be successful, that's fine with us. And most people, you know, if you think about stopping smoking or going on a diet, most people don't do it the first time. It doesn't necessarily mean that many of these patients come back to our inpatient unit, but many patients will need to come back to get some help along the way. If their physical condition changes or their social situation changes, oftentimes people do regress and find themselves in the same situation as before. Being humans as we are, we tend to not solve our problems in one fell swoop, but we do have a plan for patients of where to go if you start getting in trouble.
Okay. Well, listen, we're out of time. I want to thank you very much on behalf of the Norfolk Alliance for appearing today on Mind Over Matter. Thank you for being here.
And thank you.